Hi, my name is Barbara Willey, and I'm the president of the Healthcare District Board. And tonight is the second of our town hall meetings. We had the first one last week. But before I do an intro of Ray Hino, our CEO, I would like to have Lillian come up for a few moments and talk about her grief support group, if you wouldn't mind. Thank you, Lillian.
Every Thursday at 2 o'clock, right over here in this room, we meet with a grief support group. It's called Grief Share. And we're about in the middle of it, but each session is complete in itself. So you can come in the middle of the 13 sessions and you won't, it doesn't tie into the lesson before. Anyway, in the middle of this, we're coming up on Thanksgiving, and we're going to have Surviving the Holidays. Some of our people who are grieving would rather go to sleep the day before Thanksgiving and wake up the day after New Year's Day. So I had one of those cupcakes or whatever. I'm having a hard time talking. Anyway, Surviving the Holidays will be November the 21st, 2 o'clock in the afternoon. It's a Thursday afternoon. This is for those that are grieving and facing the holidays. It's $5. That covers a little workbook that has devotions in it. It has a lot of helps in it. And there's a 40-minute video, and then we talk, and we have some refreshments. So if you know someone that's facing the holidays without their loved one, especially the first holiday after they have gone to meet their Lord, then Grief Share, the grief support group, will finish up the week before Christmas. That's the 13-week sessions. Anyway, following that in January, I think it's about January the 7th, I'll start a session on heaven. This is open to anybody. If you're planning on going to heaven and you'd like to know more about it, come at Thursday afternoon at 2 o'clock, right over here in this room. And that is an $8 charge and that covers the workbook. It's based on Randy Alcorn's book on heaven. So if this helps you or someone you know, let them know about it. Thank you.
Thank you, Lillian. I'd like to introduce Sarah Russ is here this evening as our treasurer of the board, and Ron Peavy, sitting across the aisle, is a former board member, former treasurer of the healthcare district, and there's a couple of other usual suspects here. But I'm going to introduce Ray Hino. He's our CEO, and he came to us last January, and we're very pleased to have Ray. He came with over 35 years of healthcare experience. More than 20 of those were as a CEO in the healthcare industry, and many of those opportunities he had were in rural hospitals, which was exactly what we have here. And he had the good fortune to have been a CEO in Idaho, Sun Valley, New Mexico, Mendocino, Tehachapi. He picks very lovely places. And now he's here in Big Bear, and I'd like to introduce Ray Hino.
Thank you, Barbara. John, maybe, should I do the video before or after? Let's do before. That'll maybe flow a little bit better. We're going to start off tonight with a treat for you. We have been having a lot of fun over at the hospital. We're doing a Pink Glove dance video that maybe you've heard of and hopefully you've voted for. I'm pleased to announce that we're currently #1 in the state of California and #7 nationally. We are up against some of the biggest hospitals in the country. Our little hospital is doing extremely well. The country is embracing our video, the community's surrounding us, and it's really great. So we want to start off tonight with a little treat and show you our video. I'm thinking extended version. Not the blooper. Not the blooper. And as a real treat, we're actually going to show you the 3-minute extended version of our video. This is not the one that you'll see when you go to vote for us. So you get to see more of the story and the fun.
I've been feeling real good, came a long way from misunderstood. Far away from the days where I wouldn't wanna go home, cause I was afraid of the truth. See, I was scared to admit, the feeling was in the back of my head. Cause the point where line no longer works, so you have to stand up for how you wanna live. Tonight is the night, that we're losing control. Tonight is the night, we set it on. So everybody go. And I don't know no better, but as far as I came, it felt like forever. Seconds turn to hours, days turn to months, let a year pass by, but don't feel like much. So if I got one chance, I'ma make y'all dance. I'ma have as much fun as I can and figure out the rest when I edge out a plan. Tonight is the night, that we're losing control. Tonight is the night, we set it on. Everybody go. Everybody go. I'm feeling better than I ever thought. It's possible, but now I know. Yeah. I'm feeling better than I ever did. Impossible don't exist. No. Impossible don't exist. Everybody go. Everybody go. Tonight is the night that we're losing control. Tonight is the night we set it on. Tonight is the night that we're losing control. Tonight is the night we set it on.
Thank you, everybody. Thank you again for being here tonight. We're having a lot of fun at the hospital. Is that better? Okay. And trying to change the culture of healthcare at our hospital and locally in the community. We've received a lot of support for that video. As I mentioned a couple of minutes ago, the entire community is really gotten behind us and put us on the map so that we're #7 in the country and gaining. I'm hoping that by tomorrow maybe we'll be #6. We've got a long ways to go. Last time I checked, 800 votes behind the #6 hospital in the country, which is from Reading, Pennsylvania. Pennsylvania really showed up well this year in the in the Pink Glove Dance video competition. The number 1 and number 2 hospitals in the country are both from Pennsylvania. It's a Geisinger healthcare system, which is very similar to a Kaiser type system, and Penn State University Milton Hershey Hospital. The two of them have been trading back and forth, first place and second place, ever since the competition started last Friday. Reading, Pennsylvania is number 6. That's the one we're going for. So out of the top 6, 3 of them are currently from Pennsylvania until we kick one of them out. I want to do some additional introductions. Thank you, Barbara, for your introduction, and thank you for introducing Sarah and Ron. We also have some staff members in the audience way back in the corner. I want to introduce Kathy Norris, who's our HR director, and Marcus Armstrong, who is our CFO. Both Kathy and Marcus are new with us. Neither one of them is been on board for more than a month now. We recruited them away from other hospitals. They've both been great additions to our staff and to the community. They both moved to the community. They're both full-time residents. Marcus moved his entire family down from the Gardnerville, Nevada area just this last weekend. He felt badly that he wasn't here last week when we did our first town hall meeting, but we said that he had a very good excuse. He was moving his family, which we're pleased to see. And then I want to introduce Margaret De Guarena. Margaret works in our business office, and she's our resident expert on health insurance coverage and the Affordable Care Act, and so she is an excellent resource in here to answer any questions that you may have about the Affordable Care Act and questions about health insurance coverage at our facility. And then I think Mary Norman just walked in the room, didn't she? Did I see Mary? Yeah, there's Mary in the back as well. Mary's our Chief Nursing Officer. And Cindy Venuto. Cindy's over here.
Hi.
Cindy's our public relations and community relations specialist. She's done a great job of really getting the word out about our hospital and the services that we offer. And then I want to make a special recognition and thank you for the members of our auxiliary. Members of our auxiliary, and Nikki, our president. Our auxiliary not only is here tonight and here last week to serve as our official hostesses, but they also did a lot of telephone calls inviting people to come tonight so that we really get the word out about our meeting tonight. So thank you all for coming. Thank you to all of the staff members for being here to support me. We're hoping that this will be a worthwhile use of your time tonight. We don't want to waste your time, and hopefully you'll find this to be valuable information. We're here for you, and we'll be here as long as it takes to answer any questions. This is really about listening to you, getting your feedback and your questions and comments about what we can do better and how we can improve as a healthcare district. That's really what this is all about. So tonight's agenda is an introduction to the Bear Valley Community Hospital. Many of you are very familiar with the hospital anyway, so we'll keep it short in terms of an introduction of who we are and what we do. We'll talk a little bit about the healthcare environment, how it's changing rapidly for hospitals of all sizes, large and small. And then what's new at the Bear Valley Healthcare District, what's to be expected in the future, and we especially want to have time for you. I just noticed that Jeff Willis, our fire chief, also came tonight. So thank you, Jeff, for being here. We appreciate that. And Barbara talked a little bit about our board of directors. Barbara Willey is the president of our board, and she introduced Sarah Russ, who's the treasurer of our board. Our other board members are Donna Nicely, our first vice president, Barbara Espinoza, our second vice president, and Dr. Christopher Fagan, who is the secretary of the board. To tell you a little bit about our hospital and the board structure, we are, as you are probably aware, a public hospital. We are owned and operated by the community of Big Bear Lake and the Valley. We have been in existence since 1974, Next year we'll be celebrating our 40th year anniversary, so more to come about that. But these 5 individuals who have agreed to serve on the board of directors give of their time, a lot of time. We have lots of meetings and lots of volunteer hours that they donate to our facility. We appreciate all of them very much for their contributions on our board and for the leadership and direction that they're providing us, which I believe is heading us in the right direction. And then a little bit about me, because I always like to give you an idea of who I am. I am a California native, born in Hollywood, California, Hollywood Presbyterian Hospital. I grew up in the community of Pomona, not far away from here. I first learned to ski at Snow Summit, so I'm very familiar with this area. My mother still lives in Pomona. She's thrilled that I'm working at Bear Valley Community Hospital now. I have 2 degrees in public administration from the University of Southern California, and my master's degree is in healthcare administration and public administration. I graduated from USC with my master's degree in 1978 at the age of 24. And for the last 35 years, all I have done is work in healthcare administration. So I'm 59 years old, hitting the big 60 in a couple of months, real close to Christmas, baby. I've loved it. I've loved every minute of the 35 years that I've spent in healthcare administration. I've worked in large hospitals as large as 420 beds and small hospitals smaller than Bear Valley Hospital. I've worked in Texas and New Mexico and Montana, as Barbara mentioned, and for the last 20 years or so of my career, I've kind of specialized in the smaller rural facilities. I've found a real niche there. I like the feel of the small rural facilities. I like the fact that you can make a difference. The healthcare is important in a small community like ours. It's not just another hospital on another corner offering the same services that are available down the street. The people that live in our area depend upon this hospital, and I love the fact that I'm able to be a part of that. So I've specifically chosen to work in the smaller hospitals over the last 20 years of my career, and I felt particularly drawn to Bear Valley Community Hospital because I've watched from afar some of the struggles that the hospital has had, and I've had an opportunity to work in many hospitals just like this one, public district hospitals just like this one, same type of struggles just like this one. So I really felt like, in particular, I was well equipped to make a difference in this community, and that's what drew me to come, is I felt that I could make a difference here. I am very interested in public service to our industry as well as to the community. I've served on the board of directors for the Montana Hospital Association, the California Hospital Association, and the American Hospital Association. I found that my experience working on the American Hospital Association board was the experience of a lifetime. I was on the AHA board from 2007 to 2009. Back in that time period, not that long ago, we were just beginning to form the plan for national healthcare reform, starting to work with the White House and the administration, and I was a part of the effort of hospitals to work with the White House in terms of how are hospitals going to fit into this? How are hospitals going to contribute through a reduction in revenues for our facilities to help reduce the cost of healthcare, bend the cost curve as we referred to it, and still not devastate hospitals and healthcare as a part of the process. So I was able to be a part of that entire process, and it was the experience of a lifetime, as I said. And most of you are familiar with Bear Valley Community Hospital, so very quickly, so that you know, we offer medical, surgical, acute services. We have a skilled nursing facility. We have surgery, both inpatient and outpatient. We have an emergency department, clinical lab. Our diagnostic imaging services include CT scanner, ultrasound and mammography, as well as x-ray. We have a fine physical therapy department. Our family health center is the is the rural health clinic that's located across the street from our hospital, and soon to move into the new Brenda Boss Family Resource Center, which we'll talk about this evening. And then we have the Mom and Dad Project, which is a United Way grant-funded program, which provides parenting support to young families and provides an invaluable resource and services in this community. So we're going to talk a little bit about the political landscape and the environmental landscape and what hospitals such as Bear Valley Community Hospital and larger are facing today. This is not just our hospital, this is hospitals across the country. Hospitals across the country are dealing with reduction in profitability, value-based purchasing, which is the concept of paying for quality, which I'll talk a little bit more about, Medicare cuts, Medicaid cuts. ICD-10 is a new coding system for the way that we get paid as a hospital. That you probably are aware, we no longer get paid as hospitals based on the number of days that our patients are in the hospital or the number of services they receive, such as whether they have surgery or not, have x-rays or not, prescription drugs or not. We get paid on the basis of diagnosis. And so the coders in our institutions that document the reason why our patients are in the hospital really are the keys to how we get paid. That coding system is changing to a new system called ICD-10, which is a quantum leap above what we're currently utilizing in our ICD-9 system. Bond covenants affect those hospitals that have debt. Physician alignment is the concept of, through national healthcare reform and the Accountable Care Act, doctors and hospitals need to work closer together. Meaningful use is the concept of electronic medical records. We are installing an electronic medical record system at the hospital paid for by the federal government. In order to receive that payment, we need to demonstrate that we're actually using the system. It's not enough to purchase a computer system, take it out of the box, plug it in and say, send us our check. We actually have to show that we're using the system, that we're getting value out of it, that our patients are getting value out of it. And the good news is we just achieved stage 1 meaningful use at Bear Valley Community Hospital and qualify for the first incremental payment from the government to pay for our new system. And then bundled payments is the concept of paying hospitals based on all of the services provided and all of the providers, the doctors and the hospitals working together again, moving dramatically away from the way hospitals used to be paid. All of these dynamics are facing every hospital. And of course, you're all very familiar with national healthcare reform, the Accountable Affordable Care Act, sometimes referred to as Obamacare. As you know, along this continuum, we're currently nearing the end of 2013. The Covered California Healthcare Exchange is now in effect. California is in many ways leading the country through healthcare exchange. In the Affordable Care Act, it gives states the option of either creating an exchange themselves or utilizing the federal government for an exchange. California is one of the first to adopt it. A healthcare exchange is nothing more than a clearinghouse where healthcare insurance plans provide their products, and anyone that in our population that requires healthcare insurance, that either has it currently and would like a better deal or doesn't have healthcare insurance can go to Covered California and sign up for healthcare insurance. And we're here to talk to you and give you some resources on how to get through that if that's something that's of interest to you. The concept of the healthcare exchange is to provide health insurance plans for those that need it, either at a discounted rate if you qualify according to the income guidelines and the qualifying factors, or if you have insurance, maybe get a better deal than the deal that you have now if you individually cover yourself and or your family. You would like to see by working in as a part of a group if you can get a better deal. So we'll talk about national healthcare reform and the Affordable Care Act, and Margaret's here to help us as a resource as well. So what's new at Bear Valley Community Hospital as a result of all this change in the landscape? We talked about the Affordable Care Act already, and just to give you a few statistics on it, 94,500 applications have been started since the exchange, since Covered California became effective on October 1st. Over 1.5 million unique visits have been logged on to the website. 104,000, nearly 105,000 calls have been generated. And according to the Covered California website, the average wait time is 2 minutes for the time period of October 6th to October 12th. Some may disagree. A gentleman came to our town hall meeting last week and disagreed with that. His experience was a little bit different, but that's what they're telling us. We do want to spend some time this evening talking about the Brenda Boss Family Resource Center. And by the way, this is not about a lecture for all of you. Like I said, we want to devote lots of time to questions that you may have about the hospital and what's going on and your insurance coverage. So please know that we'll save lots of time for that. But we want to give you some facts about the Brenda Boss Family Resource Center because we know that there's lots of questions about it. Yeah, the project is currently projected to come in at about $5 million. It's actually planned to be completed by the end of this week. There are a couple of last-minute construction issues with the building that hopefully will not delay the completion any further, but the building is virtually complete at this point in time. The only things that are left to be done is there's a finish, a sealant finish for woodwork inside the building that is yet to be applied and hopefully won't take long. There's the possibility that we may have to do some reconstruction on one of the exits to the building, not one of the major ones, a side exit that may need to be remodeled. Other than that, the building is really complete. Many of you may have had an opportunity to come in and tour the building when we had the Chamber of Commerce mixer a month ago in early September, and the building showed off extremely nice. Those that came to the mixer were very impressed with the size of the building. You'll be impressed, it's very large. The reason for the Brenda Boss Family Resource Center is because healthcare is moving towards outpatient services and hospitals are moving towards outpatient services. What you'll see at the present and continuing into the future is less of a need for acute care hospitals. And you've probably experienced it in your own life that illnesses and injuries that in the past may have resulted in an admission to a hospital are now being treated on an outpatient basis. And for those that do get admitted to the hospital, the length of stay is much shorter than it used to be. Some of you may remember back in the day when a hospital admission took a week. Now, that same type of diagnosis, if you get admitted at all, you'll probably be out of the hospital the very next day. Because of the pressures to get our patients out of the hospital as quickly as possible, to provide services in the least costly form possible, usually on an outpatient basis, there's going to be a need for less hospital beds. And the future really is in outpatient services. And in the case of the Family Health Center and the Rural Health Clinic, which are the two physician office practices, rural health clinics that are owned and operated by our hospital, they have experienced phenomenal growth in the last few years. In fact, they've experienced 26% growth in just the last 2 years. So we're bursting at the seams as far as our Family Health Center and our Rural Health Clinic. The board of directors showed, I think, great foresight in planning for a building that would accommodate continued growth in that area, and the fact that outpatient services are really the future of healthcare and hospitals. So the new building will house the Family Health Center. It will also house the prenatal services that are currently being offered in Big Bear City at the Rural Health Clinic, and the Mom and Dad Project, which currently leases space in Big Bear City, will be moving over to the new building as well. Have you seen the new building? We had this town hall meeting last week, and there were some people that wanted to know where is the new building. If you've been in the general vicinity of the hospital, passed by the hospital, you will see a very large, what looks like a 2-story building going up in the parking lot of the hospital. It's not a 2-story building. It could have been a 2-story building. It's large enough, but we ended up deciding to keep it a 1-story building. And it's a beautiful building. It's going to be a great addition to the hospital. And as I said, the expected completion is the end of this week. In November, we expect to begin moving those departments from the existing Family Health Center Mom and Dad Project into the new building, so that we'll begin and hopefully complete occupying the new building by the end of November. The next thing that I want to talk to you about is the opportunity that our hospital has to become a critical access hospital. Critical Access Hospital is a program that was created by the federal government back in 1997. It was a part of the Clinton administration Balanced Budget Act. At that time, in order to balance the federal budget, there were significant cuts to the Medicare program for hospitals across the country, and legislators in Washington, D.C. were concerned that those Medicare cuts could result in the closure of essentially needed small rural hospitals across the country. They created a program called the Critical Access Hospital Program, and it applies only to small rural hospitals at least 25 miles away, 35 miles, excuse me, at least 35 miles away from the next closest hospital, unless located in mountainous terrain, like Big Bear Lake, for example, in which case the mileage requirement is 15 miles, must have a 24-hour emergency department, must be part of a rural hospital network of hospitals for support. And the benefit to becoming a critical access hospital is cost-based reimbursement under the Medicare program. In fact, it's currently cost plus 101% of cost. We've done our homework. We've completed an independent analysis by an independent accounting firm to identify what would be the financial benefit to Bear Valley Community Hospital to become a critical access hospital, and the independent consultants have come back with a report that says that our increased Medicare reimbursement and increase in funding due to participation in a federal program for pharmacy purchasing, the 340B program, is about $800,000 per year. So it is very evident to us that as a part of our recovery plan as a hospital, the Critical Access Hospital program is a key part of it. We do not have to give up a thing to become a critical access hospital. The conversion should be seamless. You won't even notice the difference between prospective paid hospital and critical access hospital the very next day. The key changes are that critical access hospitals must have no more than 25 beds. We have 30 beds right now, but 21 of those beds are skilled nursing facility beds, and they don't count. We have 9 acute beds, so our 9 acute beds keeps us well within the limit of the 25 bed limit. The other requirement is that to be a critical access hospital, the average length of stay, average, cannot exceed 4 days. It's extremely rare for an acute care patient, not skilled,
not long-term care, acute care patient, to have a length of stay in a hospital such as ours, which does not have an ICU. It's extremely rare for a patient to stay more than 4 days. And most critical access hospitals never have an issue with that 4-day average length of stay limit. Now that's average, so you can have a length of stay that's a week. You can have a length of stay that's 2 weeks, as long as you have a lot of those short stays, those 1 and 2 day and 3 day stays, so that your average remains under four days per visit. We have applied for critical access hospital designation. I've received notification earlier this week that our packet is now complete, and the next step is that our application packet will be submitted to the state of California licensing and certification so that they can schedule an inspection, a survey, to come out and inspect us. They will be inspecting us according to the federal conditions of participation. The federal conditions of participation for critical access hospitals are actually less stringent than the state of California regulations for a general acute care hospital. So we have been preparing for this survey. We brought in an experienced surveyor to come in and show us where our weaknesses are. I believe that we're ready, and very soon I anticipate we will have a survey to come in and inspect us. Once that inspection takes place, the next step is we have a set amount of time to prepare a plan of corrective action, assuming that they find deficiencies, and they always do. And then as soon as our plan of corrective action is accepted, then we can apply to Medicare for designation as a critical access hospital. My goal is to be there by January 1. I hope I'm right. Mary told me earlier today that state licensing and certification doesn't like to come to Big Bear when it snows. So we may have to apply some political pressure to get them up here anyway. I know of other hospitals that have done it, because the difference between prospective payment and critical access, as you've heard, is significant, life-saving for most of these small hospitals, and the politicians are very aware of that. Another initiative at the hospital is telemedicine. We have a new piece of equipment. We refer to it as our telemedicine robot. It's pictured in the picture here. We have one. It's in our family health center. The telemedicine robot is it's a computer. It's a computer on wheels, a flat screen monitor where our patients and our doctors and nurses can see eye to eye with a specialist who can be located anywhere in the world. I used to work at a hospital where we had hospitalists that were beaming in from Israel, anywhere in the world, and a specialist that can converse with our doctors and nurses, examine, diagnose our patients with the assistance of lab results, x-rays performed at our hospital, and then make a determination as to the best course of treatment for that patient. Number one, it's better quality care, because now we're able to bring specialists to the bedside that we don't currently have living here in the Big Bear Valley. Two, there's an opportunity. Many hospitals find that it's financially successful for them as well, because oftentimes with the assistance of that specialist coming in from the outside, now working with the doctors and nurses at Bear Valley Hospital, oftentimes those patients can be kept here and don't have to be sent out of the area, because we have a team involving specialists, which might include a neurologist, cardiologist, both very good applications of this technology. Dermatology is a really good application. I've even seen it used for orthopedic surgery, not to perform surgery, but for ER staff to bring in an orthopedic surgeon utilizing the technology to explain, this is our patient, Mary Smith. She fell today in a ski-related accident. This is the results of the x-ray and her lab tests. Do you think she needs to be transferred to a larger facility for higher quality of care? Is this something that can be taken care of here with us managing it locally? So even orthopedics can be impacted by this technology. We have it currently in the Family Health Center. We're using it for clinical psychology. We hope to add psychiatry in the near future. Those are services that are in demand and in shortage in our area, and we have found that it's a great application. Our clinical psychology clinic at the Family Health Center now is booked solid for weeks in advance, so it's working well for us. Next step is to bring that same technology into the hospital and the emergency department so that we can have the benefit of our emergency room doctors consulting with specialists, usually from larger facilities, and talking about, as I said a moment ago, the best quality of care and the best disposition for our patients. And I mentioned that we are installing an electronic medical record system, which also is better quality of care. Electronic medical records have proven to be better quality of care because doctors and nurses that have better information about the history of their patients make better decisions. And the value of electronic medical records are that it provides easy transmission of patient historical records from provider to provider, so that regardless of where you end up, large hospital, small hospital, doctor's office, you can get your records from Bear Valley Hospital or from Loma Linda or from St. Mary's, and the doctors and nurses can make better decisions. We are spending $1.1 million on the new system, and it's being paid for by the federal government because we met the meaningful use requirements and submitted our attestation on October 3rd. Another thing that I have to commend our board of directors for is their foresight in planning for the future. They brought in a consultant in November of 2011 that not only met with the board of directors, but also brought members of the community in as part of the process. And I've worked with this particular consultant before, and his approach is to involve the community as well as the board and the management team in identifying what the needs and issues are for the hospital and where the community and the board and the management want to see the hospital headed. They came up with a very good plan. It actually has 8 goals. The goals are in the areas of quality, personnel staffing, market position, affiliation, physical plant and equipment, scope of services, medical staff, and financial. I don't want to spend a lot of time on the strategic plan, but I think it's important for all of you to know that we do have a plan, and we're following the plan, and I'll talk briefly about each one. And I mentioned a moment ago that the key to hospitals in the future is through the growth of outpatient services and outpatient revenues. So there is a significant part of the plan that talks about the need to identify outpatient services that make sense for a facility of this size and a community of this size. I'm going to go back a couple steps. I thought I had a couple more slides, but I don't. So while I'm on this one, I'm just going to go quickly through the tenets of the strategic plan. It all starts with quality. Payments for hospitals nowadays are based on quality. For those, and I talked about national healthcare reform and the Affordable Care Act a few minutes ago, the way that hospitals are giving up Medicare revenues and contributing to the cost of healthcare in this country is through reduced payments through the Medicare program. And the reduction in payments is based on quality provided in hospital facilities. So for those hospitals that don't meet required quality measurements, their payments are less than they used to be. And some of those quality measurements include patient satisfaction. So if you're admitted to our hospital or any hospital, you're likely to receive a patient satisfaction survey. The results of your satisfaction survey go to a national clearinghouse, which puts all of those results on the internet, called Medicare Hospital Compare. And you can today go on to Medicare Hospital Compare and review the patient satisfaction scores for any hospital. Hospitals that have poorer patient satisfaction results than others get reduced payments. Other quality initiatives are patients that are admitted to a hospital in less than 30 days for the same diagnosis, and there's a lot of money that's spent for readmissions to the hospital doesn't get paid for that second admission. It used to be that hospitals actually kind of benefited from making mistakes, bringing the patient back for a second admission and another opportunity to bill. That's gone away. Under the new value-based purchasing and quality initiatives, hospitals are penalized for poor quality, not rewarded. Personnel staffing, we have several initiatives for training of our staff, working with larger facilities for management training, education for staff, and for uniformity. Market position, we have several initiatives there to improve our market share in this local area. Many of the initiatives include improving the signage on the highways leading to our hospital, as well as patient satisfaction scores, because patient satisfaction scores not only improve payments, but they bring more patients in the door. So we have goals related to improving market position through public relations, advertising, and providing better quality services. Affiliation is a goal that's part of the plan. Affiliation in this context means relationships with larger hospitals. And I believe that the small, independent, freestanding hospital like Bear Valley Community Hospital is in jeopardy under the Affordable Care Act and in the United States with the economy that we have today. We can't afford to continue providing the same level of services without changes somewhere. And the freestanding hospitals like ours, and I'm not just talking about the small ones, talking about the big ones too, all of the freestanding hospitals right now are looking at strategic partnerships. They're looking to see should they align themselves with a large group or system. In our case, we do have an affiliation goal. That does not mean selling our hospital to a larger hospital or system, but we're talking to Loma Linda, we're talking to St. Mary's, we're talking to Dignity Health in San Bernardino, Riverside Community, and looking to see where the win-win is for our hospital working with the larger hospital or system. Where I think it is in recruitment of doctors, because through these strategic partnerships and relationships, that frequently what happens is doctors can be recruited to serve our community, to support our hospital, that are also supporting the larger hospital. We're already doing it actually with Riverside Community Hospital, and a cardiologist who comes up here whose primary hospital is Riverside Community. We actually are talking to them about the possibility of bringing in orthopedics now, and talking with other hospitals as well that see the value in recruiting an orthopedic surgeon to come here, take care of our population, our patients, and for those things that we can't do here, refer to the larger hospital. We don't have to sell ourselves, we just have to have the right partnerships to do that, and that's key to the success of this hospital. We're looking at upgrading our physical plant and equipment. The scope of services means looking at outpatient services and services that make sense for a small hospital in this community. In the medical staff area, we've recently completed a medical staff needs plan to identify how many doctors does a community of the size of the Big Bear Valley actually need. Do we need 5 family physicians? Do we need 10 family physicians? Do we already have too many? How many general surgeons do we need? How many orthopedic surgeons do we need? How many dermatologists and obstetricians do we need as well? There are statistics that can be mined to determine a population, say 20,000 people, how many family practice and surgeons do you really need? It's important to do the study because the government requires that before we offer recruitment benefits to a doctor to relocate to this area, that we demonstrate that we actually have a need for that doctor, that we're not just throwing money at a specialist to come to our community even though we don't really need them. We've completed that study. The areas that we're looking at are more primary care, general surgery, orthopedic surgery are the top 3 on the list. Cardiology is on the list. We have a part-time cardiologist right now, but we want to demonstrate how much cardiology do we really need in this community. And then finally is financial. And I shared with you already the benefit to the critical access hospital designation. We're also looking at converting acute beds to swing beds. The advantage of doing that is it gives us more flexibility in terms of providing care for Medicare skilled patients in our facility that we've had to turn away in years prior because we didn't have an available bed. With swing beds, we can actually utilize our acute care beds for both long-term care and acute care and provide the services that are most needed. There's a very handsome margin for taking care of Medicare skilled patients, and this is an opportunity for us to take advantage of that. So then I covered this slide a little bit previously about the fact that the future really is concentrating on outpatient revenues. And a big part of profitability for our hospital is having the right managed care contracts as well. And we currently have contracts with Heritage Victor Valley, with Blue Cross and Blue Shield, with the County of San Bernardino, with Medicare and Medi-Cal, and we want to make sure that we're not leaving money on the table by having contracts in place that pays us less than other hospitals providing comparable services. Another one of the potential benefits of an affiliation relationship with a larger hospital, larger system, is the power of numbers and the clout of numbers. And if we're at the bargaining table as an affiliate of a Loma Linda or a Dignity Healthcare or a St. Mary's, our chances of getting a contract that Heritage Victor Valley or Blue Cross or Blue Shield would negotiate with a large system, generally much more favorable than what we're able to accomplish as a small freestanding hospital with no clout at all. So, almost done. Plan for a vibrant future for Bear Valley Community Healthcare District. This is my 5-point plan for success. First is become a critical access hospital. Second is to emphasize outpatient services. Third is to enter into partnership agreements with larger hospitals and systems, affiliation agreements. Always, always, always emphasize the highest possible quality of care, and also to provide efficient and productive operations. That means not be wasteful. We need to be very mindful in this economy, in this environment, that we need to be mindful of every penny that we spend and not spend them foolishly, and be good stewards of the dollars that we receive. And that brings us to questions, your questions and any answers that we can help you with. Yes?
Ray, you mentioned telemedicine, but you didn't say anything about how you're paying for that.
Okay, good question. So the question was, I talked about telemedicine, how's it being paid for? The telemedicine equipment, you're correct, is not free. We are currently leasing the telemedicine equipment that we have. It's costing us $2,000 a month to lease the equipment. We are able to bill for every service that we provide. The current telemedicine unit that's located in our family health center and being used for clinical psychology visits, it takes only 4 visits per month to, is that right now? 8 visits per month. It takes 8 visits per month to pay for the lease payment on that telemedicine unit, and we're averaging over 10 visits per week. So that's how we're paying for the telemedicine equipment at present. In the future, as we look to expand it and add a second unit to our emergency department, there's 2 avenues of payment. One is that the specialist can bill for services provided. The benefit that most hospitals experience from having that equipment, though, is through increased admissions to the hospital and keeping patients that otherwise would have been transferred out. Yes, Mary?
We also got a grant.
Oh, thank you. I was going to mention that. I appreciate that. We also, due to the foresight of our Family Health Center staff and administration and board, we applied for a $30,000 grant, which actually pays for the first year of costs of leasing the equipment. Next question? Yes?
Is the rural health clinic in Big Bear City staying open?
Yes. So the question was, is the rural health clinic in Big Bear City staying open? And it is, but it's going to primarily be a dental clinic, although the providers that are staying at the rural health clinic are Melissa Starica, a family nurse practitioner who sees patients in Big Bear City, and Dr. Brown, our dentist. They'll be staying in Big Bear City. Everything else, and the Dr. Carden and the prenatal services that are offered are moving over to the new building. Other questions? I know that you're dying, you have questions. You came here for a reason. If I don't have the answer, hopefully one of my colleagues in the room will have the answer. We're comfortable with answering questions about the Affordable Care Act, and if you have questions about Covered California or your health insurance, we're very comfortable talking about that. I turn those questions over to Margaret. She does a great job. Yes, Lillian.
I had an ultrasound done, and we went on the computer to see if Medicare would approve it. And they said they needed to have a medical review. I didn't understand what that was. But then they told me, if Medicare decides not to pay it, then you have to come up with $600 or something. I said, I'm unable to do that. We'll just not have it done.
Yeah.
But then my doctor said, well, I want to know what's going on in circulation in your legs. Go ahead and have it done. So I signed the paper nervously. Anyway, Medicare paid all but $7.89. And then United Health is my second one. And they said they didn't approve it and they didn't pay it.
Oh, the $7. So I don't know if you all heard what Lillian said. Was she was diagnosed with an ulcer, and she and her doctor.
Not an ulcer, ultrasound.
Ultrasound. Oh, I'm sorry. I thought she said ulcer. She needed an ultrasound, and she came to the hospital with an order in hand for an ultrasound, and the registration staff at the hospital ran her ultrasound order through the computer system, and they told her that they needed to inform her that there was the possibility that Medicare would not pay for that ultrasound, and if that was the case, then she would be responsible for paying for that ultrasound. She has both Medicare primary, and she has a secondary through United Healthcare as well. And that is the law. And the reason for the law is it's kind of a truth in lending and truth in advertising law. We are required, when a Medicare patient comes to our facility with orders in hand, that we need to, if it's not clearly identified in the system that Medicare will pay for this procedure and this diagnosis, it's really a matter of looking at the diagnosis that your doctor wrote and the reason why he or she felt like you needed that ultrasound. If the diagnosis doesn't match up with the procedure ordered, then we're obligated to let you know so that you're not blindsided later on and get a large bill that you weren't expecting. It's a difficult part of our work, but it's probably the right thing to do to let you know in advance that there's a possibility. Oftentimes what can happen, what we recommend oftentimes is if there is a question, that you go back to your physician and get a clarification on your diagnosis, or more documentation on what the diagnosis is. And oftentimes that can make the difference between the notice that it may not be paid for and the clear-cut decision that it will be. And in Lillian's case, she ended up, Medicare paid for all but $7, and she was hoping that United Healthcare would pick up that $7, and they declined to do so. Other questions, things I didn't cover that you would like to know more about? I'm very happy to talk about it. Anything, tell me the reason why you came out tonight. Anything that we can answer for you.
If someone does have a question on the Healthcare Reform Act, is there a resource at the hospital to come and talk to?
There is. And I want to introduce Margaret de Guarina. And I'm sorry?
My cards are here.
Yes, and Margaret, her business cards are in the back of the room on the table. Her office is located in the hospital, and we have, in this type of meeting and others like it, we've been informing the public that if you have a question about Covered California, or about your health insurance, or whether or not you may be subject to penalties under the Affordable Care Act, we ask that you come and meet with Margaret, and she'll walk you through the options and the plans that are available in our area. We don't have contracts with every plan, so it's oftentimes a really good idea to meet with Margaret and find out which plans we do accept and those that we don't, so that if you're making a decision, you can make an informed decision on a plan where you can utilize the local hospital. When we had our last town hall meeting last week, I'll maybe stimulate you a little bit. Most of the questions that came up had to do with health insurance. We had people in the audience that said, for example, I have Medicare, and Aetna is my supplemental plan, and I want to know with Medicare primary and Aetna supplemental, can I use the hospital? And what Margaret told that particular family was that the hospital accepts her Aetna insurance, but the family health center does not. Now we said that we're more than happy to take that back and look and see if it makes sense for us to have an agreement with Aetna, because our goal, and I believe the goal of everybody that was in the audience of that town hall meeting last week, was to figure out a way to use our local hospital to keep services local, and to the extent possible, avoid unnecessary trips down the hill. In that particular case, what we also told that family and others in the room is everybody is welcome to come to the Family Health Center. Everybody's welcome to come to the Family Health Center. Doesn't matter if your coverage is Kaiser or Medicare or Heritage Victor Valley, whatever. Now, the payment schedule will be different depending upon what your coverage is. And if it turns out that we do not accept your health plan at the Family Health Center, we will still see you. And Margaret, help me get this right. The charge for being seen at the Family Health Center is the discounted rate for the charge at the Family Health Center.
If you pay at the time of the visit.
If you pay at the time of visit, we will give you a discount. And the discounted rate to see a nurse practitioner at the Family Health Center is $30. So if, for example, and we told the audience last week, if you have a splitting headache, migraine headache, whatever, you really want to see a provider, it really doesn't make sense for you, you're with Kaiser and your health providers are down the hill, and you don't really want to drive an hour down the hill and pay any fees that are necessary there, you can always come to our Family Health Center, see a nurse practitioner provider there, If you pay at time of service, the discounted rate, I'll get it right one of these times, is
You got it perfect.
$30 to be seen by a provider at time of service. Yes?
Do you take walk-ins at the clinic?
Yes, so the question was, do we take walk-ins at the clinic? And that's a great question, and thank you for setting me up for that, because we're very pleased about the expanded hours. Not only, the question was, do we take walk-ins at the clinic? And we do. And not only that, but we now have expanded hours at the clinic as well. We're open until 8 o'clock in the evening, and we're open 6 days a week, Monday through Saturday. The only day that the Family Health Center is not currently open is Sunday. So if you want to see a provider after work, we're still open. And on Saturdays, we're open for working families that can't get away during the week. We've found that it's been the Saturday hours and expanded hours are very popular. We've been able to fill up our schedule. The telemedicine clinical psychology clinic that I talked about a little while ago is held on Saturday. The clinical psychologist that works with us has booked out her entire schedule to see our patients on Saturdays. So yes, we'd love to have you walk in and be seen. Yes, ma'am.
I have another one. What's the difference between going to the emergency room or going to the urgent care or going to the family health center?
So the question was, what's the difference between going to the emergency room at the hospital versus going to the urgent care center in town versus going to the family health center? Going to the emergency room will be by far the most expensive. And if you have co-pays and deductibles, that will be the most expensive out of pocket. However, if you have a true emergency situation, the emergency room might be the best choice for you. Urgent care and family health center will both refer you to the emergency room if you show up at their facilities and they feel like you are experiencing a condition that they can't handle at that facility, need to be in an emergency room. So the urgent care, we don't own and operate the urgent care. That's privately run, and I know that they provide a very good service there. Most urgent cares require cash in advance. I don't know about the policy of the urgent care here, but in most cases, the trade-off is that as opposed to going to a doctor's office or going elsewhere, there will be a requirement for payment in advance. That's possible. I don't know for certain here. And then the family health center, the advantage of going there is that, again, for the non-emergency situations, if you go to the family health center, the cost, I believe, will be quite reasonable at the $30 cost discounted rate for paying at time of visit. That is an option for you. So, depending upon the severity of illness, that would enter into your decision making, and potential out-of-pocket costs, I think, would enter into your decision making as well.
For instance, if I fall on my yard and break my arm, would I go to the family health center or the emergency room?
I think you go to the emergency room in that situation. The question was, if I fall in my yard and break my arm, we have x-ray equipment in the hospital. We do not have x-ray equipment in the family health center. Most likely you would require an x-ray in that particular case.
But if you went to the family health center with a broken arm, and you referred you to the hospital, is that an emergency room charge?
Yes.
Is it a referral?
Yes. Yeah, go ahead, Margaret.
If you are seeing a nurse practitioner and they want you to have an x-ray, they will give you a requisition for an x-ray. You will get charged for the x-ray. There are staff members that can cast. So it just depends upon the day. It's not every day they can do that, but they would then just say you would go to the emergency room instead. But they do have casting staff available.
Yes.
You laid out a very good plan. You didn't really mention much about financial recovery. Is there a projection?
A great question. So the question was, what are our plans for financial recovery? And I will tell you that we are currently undergoing our audit for fiscal year 2013. That was the year which began on July 1 of 2012 and ended on June 30th of 2013, just a few months ago. We're anticipating that we will have a sizable loss for the most recently completed fiscal year. It'll probably be in the $2 million to $3 million range. Don't know the exact figures. Marcus Armstrong, our CFO, is shaking his head yes in the back of the room. And obviously we cannot continue to incur losses of that type and continue to have a hospital in this area. And we do enjoy tax support through our ad valorem tax and our parcel tax, which helps, but losses like that are unsustainable. So the financial recovery plan is very similar to some of the keys for success that I talked about at the end of the slide. Number one, become a critical access hospital. Take advantage of that additional $800,000 a year of Medicare reimbursement that we are expected to receive. Number two, be very efficient and productive in our operations, keep our costs down to the extent possible without compromising quality of care, because we get paid on the basis of quality as well. Bring in new revenue to the facility through the swing bed program and Medicare skilled days. We also are looking at expanding our surgery department. I see surgery as a revenue opportunity for this hospital, especially in this location. We are currently processing applications for orthopedic surgeons to bring orthopedic surgeons back on staff. What I hope will happen is that we may not have a full-time orthopedic surgeon to start with, and I've done this in other communities, even a part-time orthopedic surgeon that's here for a week or two that is able to schedule patients in advance and do elective procedures. Joint replacement surgery is a good example, can be very financially successful for our hospitals. We plan to grow our outpatient and inpatient surgical business, implement swing beds, become a critical access hospital, watch our pennies and be as productive as we can. And if we accomplish all of those things, I believe that we will be a financially successful facility. Did I miss anything, Marcus? Yes, ma'am.
Does that $2 million include the new hospital, the new building?
Yes, it does. Marcus?
Well, that's actually going to be capitalized. You have to use the new clinic.
Yeah.
That's going to be capitalized. That'll be an asset on our books, and over time, we'll appreciate that. Upfront, so the $2 million this year will not include that. There might be other ancillary costs related to that that might not get capitalized for some reason, maybe some, if there were legal fees, site fees, things like that, but they should be capitalized.
Right. I mean, and so, yeah, Marcus is correct. The answer to your question on does the $2 million loss include the new building? When we talk about $2 million loss, we're talking about the income statement for the hospital, our revenues and our expenses. And our revenues and expenses does not include the new building. That's a cash outlay, but it's not related to our costs for doing business. So that $2 million actually does not include the cost of the new building. The new building does have an effect on our balance sheet and our cash on hand. Yes, John.
I know on the ballot next November is the renewal of a tax. It's not a new tax, but it's a renewal of a tax. Can you real briefly say what happens if that does not get approved by the voters?
Sure. So John's question was reminding us all that next year we are likely looking at a parcel tax initiative on the ballot. And if you're not aware of that, I'll spend a couple minutes and talk about that too. And then John's further question was, what happens if that doesn't pass? So here are the facts regarding the parcel tax. The hospital district has had a parcel tax that has been in effect since 1995. Since 1995, local property owners have paid for improved properties $45 per parcel per year. For unimproved properties, and those that do not have buildings on them, the cost has been $25 per year. The initial parcel tax was voted on in 1995. It was renewed, it was voted on and approved for 10 years. It was renewed in 2005 for another 10 years. And unless it is voted in again before June 30th of 2015, it will expire. So it brings in about $1.1 million per year to supplement the loss that the hospital is currently incurring, or in other words, that $2 to $3 million loss would be another $1 million loss if we didn't have that parcel tax. With that in mind, the board of directors has hired a consultant to help us create a public awareness campaign to educate the community as to exactly what John's talking about. You know, what will happen if that parcel tax does not pass? And with that in mind, the board is tentatively planning on including a parcel tax ballot measure on the primary election ballot in June of 2014. That's a whole year before it expires, but there's a good reason to do it a whole year before it expires. And that reason is that if it doesn't pass in June of 2014, the district has a chance to run it again, either in November of next year or as a special election, to get a second chance to pass it before it expires on June 30th of 2015. If it doesn't pass, then we'll be forced to look at services that are provided at the district. As most of the community knows, we did do a reduction in force earlier in the year. We slimmed down as far as a facility and eliminated some positions. You can only do that for so long. And you get to the point where you're cutting into muscle and bone, and we're getting close to that. The next thing to look at when you get into that situation, when you're looking at a potential loss of $1 million from your bottom line, the next logical place to look is at services at the facility, and not to make any predictions, because I think it'll pass and we won't be in that situation, but we would have to make some hard choices. We'd have to look at the surgery service and see, is the surgery service a positive benefit to the hospital or a negative? If it's a negative, then that would be something that have to be seriously looked at. Other services at the hospital that are currently available would have to be looked at as well. Not some place that we really want to go to. A $1 million loss would be fairly devastating, and so it would put us in a place where we would have to, the hospital would no longer look the way it is right now, for sure.
Is it going to remain the same, $45?
Excellent question, and John kind of alluded to that as well. The question was, and I'll get to you in a second, Mia, is the board thinking of keeping the $45 the same at $45, or is it looking at increasing it? At present, the board is looking at keeping it at $45 and not increasing it. The reason is that it's a lot more palatable and easy to sell to the community that this is not a new tax. This is a tax that's been in place for 20 years now. You've been paying it for 20 years, and we're not increasing taxes or adding any taxes. That makes it a lot easier. If we were to look at an increase to that $45 amount, it would become incrementally more difficult to pass. And it's much more important from my perspective to pass it at $45 than to risk losing it by trying to go for more. Yes, ma'am.
Well, I'm changing the subject.
Okay.
How does the Covered California compare to the national program? I mean, you hear of things like, figures like the Blue Shield has dropped 160,000 people in California. So is it on the, pretty much on the same problem level and as the federal?
Great question. The question was, how does Covered California compare to the health exchange on the national level? And as I said a few minutes ago, states were given the choice. They can create their own health exchange for their state, or they can use the federal program. Most of the experts that I've heard from and talked to feel that it's an advantage for us in California to have our own. To have our own and to be able to offer products that make sense for Californians and is tailored for our population is, I think, an improvement over what other states are going to have to deal with when they get a one-size-fits-all type program that is made available through the federal government. I don't know, Margaret, do you have any additional thoughts?
Just that I've understood that our plan is much easier to access. There are 4 levels within each plan, and there are 4 different plans. And that's in addition to the federal state plans such as Medicare and Medi-Cal.
So Margaret's answer is what she's heard is that the California, Covered California is easier to access than the federal health exchange is, and offers more plans. It offers 4 levels of 4 plans and offers more plans than the federal health exchange offers, so that Californians do have more choices.
And more customized to your needs.
More customized to your needs, which is kind of what I said a moment ago, not the one-size-fits-all plan that those states that do not have an exchange will be offering. I won't forget about the drawing. So does everybody have a raffle ticket?
You talked about what's moving in the new building, but what's going in the existing building?
Another great question. The question was, we know now what's going into the new building. What's going into the building that's going to be vacated when the new building opens? And current plans are to move our physical therapy department into the new building. Physical therapy is one of the services that is growing rapidly at the hospital. They are constrained by space. They're working on top of each other. They're not able to grow their business at the rate that they could if they had more space available. So the thought at this point in time, my recommendation to the hospital board has been to move physical therapy into that building at the least possible cost. We can't afford to spend a lot of money to renovate that building for physical therapy. So the plan is to move it over, keep the walls and the layout pretty much the same as it is right now, expand our business without expanding cost. The other thing that we want to do in that building is to add doctor's offices. As I mentioned, we're talking about the possibility of orthopedic surgeons that might be here a week at a time, will not have space in the community. We'd like to be able to offer them space in our building so they can see patients in our building. There's a nice connection between orthopedics and physical therapy anyway, so that's kind of a nice combination. Other thoughts and plans are that then with physical therapy vacated, what we would like to do is move a meeting room, which is tying up critical clinical space next to our emergency department, and use that as an opportunity to expand our emergency department, which as you all know, is extremely busy during the winter months and burdened with a lack of space, that we would have more space for our emergency department. So it's a nice domino type effect. Yes, Barbara?
I just wanted you to mention November 5th.
Yes. And so Barbara reminds me to talk about the fact that the next week, on Tuesday of next week, we are going to be having our second Bear Valley Community Healthcare District Financial Summit of the year. You might wonder, why are we doing that a week after having this meeting? The summit is an opportunity for us to go into a lot more detail about our plans at the hospital, the future of the hospital. We plan to devote quite a bit of time talking about the Affordable Care Act again. We find it to be, it is a follow-up to the summit that we held earlier in the year, where we talked about the challenges that our hospital is currently facing, what we're doing about it. In a way, it's going to be kind of a report card. We told you 6 months ago that we were going to be converting to critical access, that we were going to be opening swing beds, that we were going to be more efficient in our operations, and this is what we've done. And these are what the next steps are. That will be next Tuesday, November 5th, beginning at 6:00 p.m. at the Summit Church on Garston Drive, right across the street from the hospital, or at least kitty corner from the hospital. Beginning at 6:00 p.m. And for those of you that attended the first one, we expected to be a lot less detailed in terms of graphs and slides and historical utilization of the hospital, and more time spent on what's actually happening at the hospital and what we're doing about it.
Are you bringing the dancers to that?
We will. We absolutely will. That will be 2 days before the final day of voting for the pink glove dance. So we will actually probably have. Yeah, that's a great idea, John.
Have a laptop there so we can vote while we're there.
That's right.
That's a better idea.
Maybe we'll have some live pink glove dancers. That could actually be a lot of fun. Any other questions before we let you go for this evening and have our drawing? Well, I want to thank you all very much for coming out this evening. How many do we